Well, thank you everyone for joining us today. This presentation is part 4 of our Navigating ALS series, and it's about managing ALS in the Multidisciplinary Clinic. We have a guest speaker here that we'll introduce in a little bit. Just a couple of reminders. We are recording this presentation, and we will send the recording out to you all afterwards. And the best view to listen to the presentation and view it is in speaker view. That way you will get to see the presenter and the presentation at the same time. If everybody will keep themselves on mute during the presentation, just to minimize background noise, that'll be appreciated. If you have any questions or comments during the presentation, please use the chat box. It's usually at the bottom of your screen. If you move your cursor around, it should show up with that option. So enter any questions or comments at any point in the presentation, and we'll be glad to address those at different points. So thank you again for joining us today. For those of you who are just jumping into session 4 and haven't attended the other ones, we have 3 other sessions in this series. And so we'll start back over with session 1 next month. So look out for communication on that, and you can join us for that session and pick up into the series. So with that said, I will pass it over to Linda.
Hello. Next, we have our guest speaker, Pam Kittrell. She has held many roles, which include our former clinic coordinator for our weekly ALS multidisciplinary clinic in San Antonio. Pam has worked in research with Dr. Jackson for nearly 18 years and currently serves on the NEALS Executive Board as the Clinic Research Coordinator Representative. We are happy to have her here today to present on multidisciplinary care. Pam?
Thank you. Thank you, Linda, and everybody. Good to see everybody. We're going to talk today about multidisciplinary care. Next slide. And basically, multidisciplinary care is really a comprehensive care from a team of specialists. And that's often used in treating complex medical conditions. These clinics are under the direction of a physician, and each member of the team has some very specific responsibilities. It also provides a continuum of care so that when we see our families and our patients that are living with ALS, we can look at how they were from visit to visit, and we have that consistency of these providers. It really integrates that care. It's sort of like one-stop shopping, if you want to call it that. And we have some pretty good evidence that this really can improve patient satisfaction and empower our families and the patients to be active partners in their care. It helps us to use time a little bit more efficiently. People don't have to go from place to place, from visit to visit, and also improves provider satisfaction because we learn new skills from one another, we understand other disciplines better, and it allows the provider to focus on the individual area of expertise. This is used in diabetes, breast cancer, heart failure, rehabilitation, psychiatry. There's lots of different places that use multidisciplinary approach. The team members you'll typically see in an ALS clinic will be the neurologist, the physical therapist, occupational therapist, speech therapist, respiratory therapist, dietitian, counselor, social worker, assistive technology professional, the ALS Clinic Coordinator, the ALS representative. There might also be neuropsychologists, pulmonologists, VA benefit representatives. It really depends on your clinic. Every clinic is a little bit different, and you may not see every single provider at every single visit. Next slide, please. So as we said, the benefits of this approach is that you have ALS experienced providers and therapists. They provide convenience for the families and for the patients. It's collaborative, it's more holistic, and really it gives you a good sense of what's available in your community so that you can access those things that are available for care. Next slide, please. The neurologist basically is sort of the captain of the ship, and they will do a neurology exam to look at status and see if there's been any change or progression. They prescribe the medications, Riluzole or Radicava for ALS. They also provide the treatments or recommend treatments for muscle spasms, cramping, excessive saliva, any mood, anxiety, or sleep disturbances. They can order procedures or medical devices to help with breathing, nutrition, speech, and mobility. And also, because we see people regularly in our clinic situations, we can begin to do some anticipatory guidance. We can begin looking each time as we get to know our patients and their families, we can begin to think, what might we be needing sometime in the next month or so, or the next 2 to 3 months, and give us some sense to a little bit of how things are progressing in the for those patients. Next slide, please. The physical therapist is the person who really does strength and mobility assessment of your large muscle groups in the arms and legs. They can talk about range of motion and stretching exercises and provide information on that. We talk about energy conservation techniques, transfer training, fall prevention strategies, mobility device recommendation and fitting, things like braces and perhaps a cervical collar fitting, those kinds of things. They do the overall large assessment of how the patient is doing and as compared to previous visits as well, and make recommendations for things you might need in the home. Next slide. The occupational therapist is one who really looks at those fine muscle or fine motor, those smaller muscle groups, hands and fingers, and they do specific range of motion and stretching exercises as well, and also help to provide some solutions for activities of daily living, things like toothbrush or hairbrush or eating utensils. They fit for wrist splints and braces. Occupational therapy and physical therapy often work hand in hand, and they often will do their study of the patient, or look at the study, look at the patient at each visit together, because they are working side by side. And so don't be surprised if you see them together at a clinic visit. And they can also cover for one another to some extent to help identify if one or the other of them isn't available. They can help then refer and make those recommendations for the families. Next slide. The speech therapist is someone who really looks at speech and swallowing. They can assess the swallow function right in clinic, or they may actually recommend that it be done in another center. So in other words, a bedside exam versus an exam that might be done under X-ray or barium swallow type exam. They teach some safe swallow techniques. They can recommend dietary changes looking at swallowing function. They can help talk about when it might be appropriate to talk about a PEG tube or some kind of a feeding tube to get nutrition, so we don't have choking or aspiration into the lungs. And they also look at speech function and recommend different types of devices that can be used to help with speech issues as patients move forward. Next slide, please. The dietitian often works hand in hand with the speech therapist. Sometimes they do individual visits, sometimes they do them together, but the dietitian's job really is to look at nutritional status. We usually weigh patients at every visit. We want to make sure you're maintaining the best nutritional status as possible. They look at calorie demands. We know that people with ALS are kind of burning machines, and so we need to make sure you're getting in enough calories to maintain muscle mass and energy. Sometimes it gets more difficult to eat, either because it's harder to get the food into your mouth, or just the process of chewing and swallowing and getting through a meal is so tiring. They then can also work with decision making on PEG tubes, and then helping to just prescribe various nutrition through the PEG tube. We see PEG tube as an adjunct kind of therapy, especially if we're trying to get in adequate hydration, if pills begin to be a problem, that kind of thing. This is where both the speech and the dietitian can help look at where do we need to go next. Again, next slide. So pulmonology, respiratory therapy is going to be different from place to place. Right now, for example, in San Antonio, we're not doing any pulmonary function tests in clinic. That may change as things change with COVID. Some places have a facility where you can easily be tested, and then those rooms can be isolated as needed. But sometimes pulmonary function tests can also be done at home. We look at the pulmonologist or the respiratory therapist can also recommend different devices to help support breathing and to help loosen up and move those secretions. These are things like BiPAP, AVAPs, or Trilogy. You'll hear those terms used. Cough assist to help if it's getting difficult to cough or those muscles are becoming weakened, and then a suction machine. So these are all things that get recommended by either the pulmonologist or the respiratory therapist. Sometimes we will refer the patient and family, to the pulmonologist outside of the facility, and we usually have somebody that we work with who is familiar with ALS and knows some of those specific needs. We also talk about how to prevent respiratory complications like pneumonia, and this person can be helpful in managing those excessive secretions and making recommendations. And they can assist with referral to ear, nose, and throat or pulmonology if it got to the point where some kind of invasive ventilation option was necessary. You will typically see a respiratory therapist in the home as well if you get to that point, and they can help make recommendations in terms of different kinds of masks or different kinds of pressures that might be necessary to help make it possible to effectively use the non-invasive ventilator that might be prescribed by the doctor. Next slide, please. The counselor can take a number of different forms. Sometimes it's a social worker, sometimes it's a psychologist, and these people can help to assess the emotional and psychological impacts of ALS. They can help provide individual or family therapy, can assess for caregiver fatigue, and help review some strategies to prevent this. The counselor or the doctor or the nurse may refer to the neurologist or psychiatrist for medications. It is not surprising. We do see people who sometimes need some help with medication or from therapy. This is a difficult diagnosis. And the counselor can also be the support group facilitator. Now, again, reminding people, every clinic may not have someone on site at every clinic, but we all have access to those individuals that we can refer to. So, and we encourage people, don't hesitate to ask for help if you need it. Next slide, please. Social worker is really a key person. They can help this disability application process. We know that ALS is a disease that is, the disability process can be more quickly accessed. They also are good resources for accessing community information and who can be connected. Long-term care decision-making, if you've got long-term care insurance, they can help with facilitating that, as well as advanced care planning. Again, a social worker sometimes can be seen just through a Zoom type call or a telemedicine visit. They may not be available in the clinic, but they can be a wealth of information for finding your way through the process. Next slide. So the assistive technology professional is someone who can help with proper fitting of the mobility devices like a wheelchair and things like that, and help tailor device to the patient needs and troubleshoot issues. I know in San Antonio, we don't have someone in clinic every time, but we do have people that we can send to the home. And sometimes you can have physical therapy or somebody come out to the home to help double check and see how those things work and what we might use to help it more functional in the home. We also have our own, loan bank professionals who can help with getting those things fit and functioning in the home for the families. Next slide, please. The ALS Association representative is really the liaison between the patients, caregivers, and the ALS clinic team. And there's usually someone from the ALS Association present at every clinic. They help manage the loaner equipment. They can help with the support groups and coordinating support groups, community resources, and providing resources to the family. Virtual educational presentation and workshops like today. Same thing happening there. They are the people that we refer patients to, and they refer patients to us in our clinics and help try to get people connected in the way that they need to be connected. Next slide. And the ALS Clinic Coordinator is really someone who helps guide patients into the clinic. Again, liaison between the patient and the clinic team. And they are usually present at the clinic visits to help sort of streamline that visit to focus on the needs of the patients, help us identify who might need to be fast-tracked or who might need some additional support. And they really help to ensure effective collaboration between the providers and the therapists. This is really, it's really important to have a comprehensive assessment and coordinate those assessments and communicate what needs to be done, and then consistency in the message. And that's really where the clinic coordinator can be extremely helpful across the board. Next slide, please. So in preparing to come to clinic, I think this is true for any doctor visit, but it's really true in the clinic visits, because we find that often people get there and they'll may talk to the dietitian, and then the next provider will come in, they'll say, oh, I forgot to say this, or I forgot to ask that, or I forgot to ask Dr. Jackson. So bring somebody with you. Another set of eyes and ears is really important and helps us all remember what needs to happen or what kinds of questions had been burning in the last few weeks before clinic. Again, writing those questions down in advance. It's a good idea to check all your prescriptions and check for refill needs in advance. It's increasingly complicated to get refills done in today's world, even though we think it should be easier. And so we like to know that it's not last minute. It's very hard to get something done in less than 48 to 72 hours. So double check with your pharmacy and see where your refills are, and talk with your doctor when you get there and bring that so we can be sure that your refills are met. Remembering that each neurology team may work differently. Some things need to be prescribed by your primary care doctor. So make sure you know what drugs are being prescribed by primary care versus those drugs that are prescribed by the neurologist in clinic. It's important to be prepared to stay for several hours. Every clinic runs a little bit differently, and so it can be anywhere from 3 to 6 hours depending on a clinic. And so be prepared for that. Bring the equipment that you might need, bring supplies that you might need. If you are somebody who gets hungry, you might need to bring a snack. Just be prepared for that. We usually can provide water and some of those kinds of things, but again, every clinic's different, and what they have access to and the space may be different. So be prepared for that. Bring your communication device. That's really important. Sometimes people leave it at home thinking it's not important, and then there's a lot of talking that goes on in clinic and a lot of checking on how things are working. So be sure that you bring those devices that you might need for support and for communication. Sometimes clinics are very cold, so I encourage people to bring a blanket or a sweater or something that you might need to help you stay comfortable. Pillows, props, those kinds of things that you might need. Remember to take notes and ask questions. Don't be afraid to ask questions. We're all always learning, and we want to be sure that your questions get answered if at all possible in the course of a clinic visit. And then make sure when you leave, you have an understanding of what is the plan of care, what's been prescribed. Are you going to be needing to go somewhere for an additional visit, like an EMG, or are you going to the pulmonologist, or might you be going to see the gastroenterologist? But what's the plan? Who do you need to call them, or has an appointment been made and you should be hearing from them? Make sure you know who you're hearing from and phone numbers for those other providers. What are you supposed to do when you leave? Is there any homework for you? Make sure you understand what's going to happen when you leave and who you need to talk to in the event that those things don't happen. Next slide, please. So in terms of continuity of care, we think that quarterly visits are pretty standard. In other words, about every 3 months, you can expect to come in and see the team. As the neurologist gets to know you, as the team gets to know you, as we begin to understand better how your disease is progressing, those visits might spread out a little bit. Maybe it'll be every 4 months or even every 5 months. But at the very beginning, you can expect to come about every 3 months, because it helps us get a picture of how things are going, how you are progressing, how things are changing for you. They may want you to come in 2 months after your first visit. Just realize that there might be some flexibility there as things are changing. It's important to know who to contact for questions in between visits. Some clinics, they may give you access to every provider, and you can reach out to them in their preferred method by phone or by my chart, that kind of thing. But know who to reach out to in between visits. You can always ask about virtual care options. COVID, if nothing else, has given us a whole new way to stay in touch with our patients and their families. And especially for some patients for whom travel has become very, very difficult, the telecare or the virtual care options are really important and allow us to stay in touch. It's also important to have sort of 1 or maybe 2 care advocates within your team or your family. If 7 people are calling and asking the same question, often the answer just gets delayed or doesn't get communicated fully. So if you have 1 or 2 people who are your key advocates, those are the people who work with you and work with the care team to help make sure we have good communication and clear communication. I'll encourage people to set up my chart or whatever your patient portal is in your location. You can ask questions. Sometimes we think about things at 2 in the morning or 4 in the morning or 6 in the morning. If you have that portal set up, you can send that request in and get that taken care of, hopefully more quickly than if you're leaving a message or waiting on the phone. We always encourage people to reach out if things have really changed. If we saw you in February and you're not coming back till May, but boy, the beginning of April, something really changed, it's important for us to know that. We would rather know if there is something happening, and we might be able to bring you in early, or we might be able to set up a virtual appointment. We might be able to act on those changes more quickly. We don't want to wait till things are really desperate or you feel like you have to go to the emergency room. We'd like to be able to stay on top of things as we move forward. And that's why it's important for us to hear from you if something really changes significantly between visits. Next slide. Okay, boy, I buzzed through that.
I don't see any questions in the chat. I think you pretty much covered it pretty thoroughly.
Yeah, I think it's another thing to remember is that we always feel like the team isn't really just treating the ALS, but we're treating the person who has ALS and the whole family. And so that's really, I think, an important piece in all of this is remembering that our job is to help the whole and have that holistic approach.
All right. I don't see we have any questions today. Let me bring my face back up here.
I see something from, he says, I'm not able to get into the clinic. Should I look elsewhere? I'm not sure which clinic that is, but or where you're located. October is a ways away to get into clinic. Oh, UT Southwestern. Okay. I could probably defer that to the Dallas people. There are a couple of other clinics. I don't know if it's I'm thinking of.
There's Texas Neurology there.
Yeah, I'm thinking of Dr. Heitzman. That's Texas Neurology. You might contact them. Dara Heitzman, Texas Neurology. I don't know if you're between Dallas and San Antonio there. Yeah, thanks, yes. Steve. That is a long time to wait to get in for, and sometimes, you're in Frisco. Yeah, so you really are up in the, I was gonna say, if you're between Dallas and San Antonio, there's a couple other ones I can think of, but yeah, you might reach out to them and just explain that you're trying to get in to see somebody and you're, the next.
Here's the contact. Thank you, Steve.
Yeah, thanks, Steve.
Anybody else? Right. Well, as usual, Pam, I want to thank you for presenting for us. You always do such a great job, and some people don't realize the importance of the multidisciplinary clinic, and it really is. It's just the best plan of care. So thank you for covering everything. And
I was going to say there's some interesting research on that. And the American Academy did some work on this as well, that there's some very good indicators that people who regularly go to a multidisciplinary clinic just do better over time. And that's probably because you're being followed. We're looking at everything that's happening and staying on top of things. And that can really make a big difference as we look at different things, different interventions and different things that need to be added to the care.
Very true. It's very true. It takes the guesswork out of it. Yeah. Because there's a lot of areas to navigate with this disease. And so, also too, I mean, I know with COVID, it was a little different. We used to tell people, bring whoever you want. Now I think most places will allow you to bring one person, but do that because there's so much information that comes out of this that you possibly can't absorb it all. Yeah. And so I always bring somebody else with you, take some notes, and then there you go. You have all of us. So there's Serena, me, Linda, and Jordan. We cover different areas of the state. If you do have any questions after this presentation, please feel free to reach out to us. But that's just any time in between clinic and in between your next clinic visit. If you have any questions or thoughts or concerns and you don't know where to go or who to turn to, that's us, and we can most of the time help you get to where you need to be. Here's Tanya Hitchman. She's our program director, and she does different groups for youth and children, caregiver programs. Sometimes she'll do some cooking things. And so, yeah, always stay tuned to what's going on. Things are constantly being added and changed. And then we have our equipment guru. This is our very own Marshall Knudsen. And Marshall can help you with different equipment that we have available in the loan bank, sometimes just sending things to your house, but also help you work through if you're having an issue. Of course, we can do this too, but Marshall can help you with, if you're having some kind of an issue, how are we going to overcome that issue? So, yeah. And then again, as usual, thank you for attending. I just want to remind you that this is being recorded and it will be emailed to those who registered. Our next session is May 10th and it's called Understanding ALS, and I believe that's at 12:30. So stay tuned for some more publication about that. Contact information, and I think that's it. Thank you again for joining us.